알겠어.
Answers and explanations. 1. Correct answer, E. Agranulocytosis. Explanation, polycythemia vera, a condition characterized by the overproduction of red blood cells. Bacterial infections are not a typical first sign. Acute myeloblastic leukemia, AML. While AML can compromise the immune system, leading to increased infection risk, it's more directly associated with symptoms related to bone marrow failure. Idiopathic thrombocytopenia primarily involves low platelet counts leading to bleeding issues, not typically presenting first with bacterial infections. Chronic myelogenous leukemia, CML, similar to AML, while it can lead to increased infection risk, it typically presents with symptoms related to high white blood cell counts. Agranulocytosis, characterized by an extremely low neutrophil count, leading to a significant vulnerability to infections, including bacterial. It is thus highly plausible for bacterial infections to be an initial sign. 2. Correct answer, E. 1 cell. Explanation, 1 billion cells. This stage would represent a significantly advanced stage of neoplastic disease, not the start. 2 cells. While neoplastic clones can expand from a single mutated cell, starting from exactly 2 cells is less typical as a description of origin. 100 million cells. This number indicates a very advanced neoplasm, far beyond the initiation phase. 1 million cells. This would already represent a growth beyond the initiation stage. 1 cell. Neoplastic disorders typically begin with a single cell that acquires mutations, allowing it to proliferate abnormally, thus representing the initiation of neoplastic disease. 3. Correct answer, B. Remove leukemic cells. Explanation, collect platelets. While cytophoresis can be used to collect platelets, it's not the highlighted correct answer here. Remove leukemic cells. Therapeutic leukapheresis, a type of cytophoresis, is used in cases of leukostasis, extremely high white blood cell counts in leukemia, to rapidly decrease leukemic cell counts and reduce symptoms or prevent complications. Collect stem cells for transplantation. Although cytophoresis is used for this purpose, it is not the answer marked as correct here. Determine cell phenotype. This is not a function of cytophoresis. Typically, laboratory analysis after cell collection would be used for phenotyping. Perform controlled cell transfusion. While related to handling cells, cytophoresis itself is more about cell removal or collection than the process of transfusion. Casharb answers and explanations. 1. Correct answer, C. Evaluate cell phenotype. Explanation, collect platelets. Cytophoresis, specifically platelet pheresis, is commonly used to collect platelets for transfusion purposes. Remove leukemic cells. Leukapheresis is utilized to remove excess leukemic cells from the blood in cases of high leukocyte counts, as seen in certain leukemias. Evaluate cell phenotype. This is not a function of cytophoresis. Phenotyping of cells is typically done through laboratory analyses like flow cytometry after collection, not during the cytophoresis process itself. Collect stem cell for transplantation. Stem cell collection via apheresis is a standard practice for gathering hematopoietic stem cells from peripheral blood for transplantation. Perform controlled cell transfusion. Cytophoresis can also be used to collect specific blood components for controlled transfusion to patients. 2. Correct answer, C. Bortezomib. Explanation. Gefitinib, an EGFR inhibitor used primarily in the treatment of non-small cell lung cancer. Rituximab, a monoclonal antibody against CD20 used in the treatment of diseases with B-cell malignancies such as non-Hodgkin lymphoma. Bortezomib, a proteasome inhibitor that interferes with the degradation of proteins involved in cell cycle regulation, used especially in the treatment of multiple myeloma and mantle cell lymphoma. Imatinib, a tyrosine kinase inhibitor used primarily for chronic myelogenous leukemia, CML, and gastrointestinal stromal tumors, GIST. Anagrelide, used to reduce platelet levels in conditions like essential thrombocythemia, not a proteasome inhibitor. Number 3. Correct answer, B. 250 milliliters. Explanation. 100 milliliters. This volume is smaller than the typical collection for platelet concentrates. 250 milliliters, a standard volume for a single unit of platelet concentrate collected during apheresis. This volume can vary slightly depending on the collection system and patient specifics. 500 milliliters, generally considered too large for a single unit of platelet concentrate. 1,000 milliliters, far exceeds typical volumes for platelet concentrates, generally representing total blood volume processed, not the final product volume. 50 milliliters, too small to represent a functional therapeutic volume of platelet concentrate. Answers and explanations. 1. Correct answer, A. 300 milliliters. Explanation. Plasma bags used in medical settings, such as for plasma collection during apheresis, are typically designed to hold around 300 milliliters. This capacity allows for efficient processing and storage of plasma for transfusion or further manufacturing. Other sizes like 150 milliliters, 200 milliliters, and 50 milliliter could be too small for standard plasma donation sessions. Number 2, correct answer, B. Explanation. Bone marrow, not the site of action for acenocumarol or warfarin, as these drugs do not affect blood cell production directly. Platelets. These anticoagulants do not act on platelets. They do not affect platelet function or count. The stomach. Not relevant for the mechanism of these drugs. They do not act on the gastrointestinal system. Blood clots. While these drugs affect clotting factors, their action is not directly in the clots, but in the synthesis of these factors. The liver, acenocumarol and warfarin function by inhibiting the vitamin K epoxide reductase complex in the liver, crucial for the carboxylation of several clotting factors. This action reduces the liver's ability to produce functional clotting factors, thus exerting an anticoagulant effect. 3. Correct answer, D. Blood clots. Bone marrow, not the site of action for low molecular weight heparin, LMWH, as it does not influence blood cell production. Platelets. LMWH mainly acts on factors in the clotting cascade rather than directly affecting platelet function or aggregation. The stomach. Not the action site for LMWH. It is administered subcutaneously and does not interact with the gastrointestinal tract. Blood clots. LMWH primarily works by inhibiting factor XA, a key enzyme in the blood clotting cascade, thereby reducing the formation and growth of blood clots. The liver. Unlike warfarin, LMWH does not act in the liver but directly influences clotting processes at the site of blood clots. Answers and explanations. 1. Correct answer C, between 3 to 6 cent. Explanation. It seems there is a misunderstanding or typo in the options provided, as they refer to percentages that are not clear in the context of blood transfusion criteria. Typically, the indication for a blood transfusion is not based on a percentage, but rather on clinical signs, hemoglobin level, and the patient's overall condition. For hemoglobin, a hemoglobin level below 7 grams 70 grams per liter, 4.34 millimeters, is generally considered an indication for transfusion in many clinical settings due to the risk of symptomatic anemia, especially if the patient is showing signs of poor oxygenation or significant cardiac distress. However, the decision can vary based on individual patient factors and clinical judgment. 2. Correct answer C, intravenously. Explanation. Intraperitoneally. This is not a common route for the transplantation of hematopoietic cells, as it does not facilitate direct access to the bone marrow. Intramedullary refers to injection directly into the bone marrow, not typically used for hematopoietic stem cell transplant, which aims for broader systemic distribution. Intravenously. Hematopoietic stem cells are typically infused intravenously. This allows the cells to enter the bloodstream and home to the bone marrow, where they can engraft and begin producing new blood cells. Subcutaneously, not used for stem cell transplantation, as this method does not provide direct access to the vascular system or the bone marrow. Intra-arterially, not applicable for hematopoietic stem cell transplantation, which requires systemic distribution that is best achieved through venous infusion. 3. D. Stem cell source. Explanation. Need for special precautions during neutropenia. Both autologous and allogeneic transplants require precautions during neutropenia, though the risk and management might differ slightly due to the potential for graft versus host disease, GVHD, in allogeneic transplants. Stem cell harvesting method. Generally similar for both autologous and allogeneic transplants, typically involving mobilization with GCSF followed by collection via apheresis. Need for chemotherapy and/or radiotherapy conditioning before transplantation. Both types of transplantation often require a conditioning regimen to prepare the body, though the intensity and specific agents used can vary. Stem cell source. This is the primary difference. Autologous transplants use the patient's own stem cells, collected and possibly treated before being reinfused after conditioning. Allogeneic transplants involve stem cells donated by another person, which introduces additional complexities such as matching and the risk of GVHD. Answers and explanations. 1. Correct answer, C. A molecule of transferrin may transport 4 atoms of iron. Explanation. A unit of blood contains 200 to 250 milligrams iron. This is correct. Each unit of donated blood contains approximately to 250 milligrams of iron, mostly within the hemoglobin of red blood cells. Bleeding is the major cause of iron deficiency, also correct. Chronic blood loss, often from sources such as gastrointestinal bleeding or heavy menstrual periods, is a primary cause of iron deficiency. A molecule of transferrin may transport 4 atoms of iron. This statement is incorrect. Each molecule of transferrin can bind up to 2 atoms of iron, not 4. A man needs to absorb about 1 milligrams of dietary iron daily. This is correct. Adult men typically need to absorb about 1 milligrams of iron daily from the diet to replace losses and maintain adequate iron stores. 2. Correct answer, B. A reversible preservation technology for live biological objects, which is based on using clathrate-forming gaseous substances under increased hydrostatic pressure and hypothermic temperatures, irreversible. Explanation. The terminology here seems to be confusing or contains a contradiction. Cryostasis typically refers to the use of cold temperatures to preserve biological specimens, possibly involving reversible methods. The explanation given in option B suggests a process that involves clathrate formation, cage-like structures formed around the guest molecule by water or another host, which could be aimed at preservation. The use of the term irreversible may be incorrect or typographical in this context if indeed the process is intended to be reversible. More commonly, cryopreservation techniques aim to be reversible, allowing biological specimens to be effectively restored to a functional state after thawing. 3. Correct answer, E. Above 50 by 10 E9 Ls. Explanation. Above 150 by 10 E9 La, higher than necessary for most procedures. Typically, this is the normal lower limit for platelet counts. Above 100 by 10 E9 Fry-Eller in major surgical operations. For major operations, a platelet count of at least 100 by 10 E9 Lig is often targeted to minimize bleeding risks. Above 70 by 10 E9 Lel-Fry, this may be adequate for minor surgical procedures, but may not be sufficient for more significant surgery. Above 10 by 10 E9 NLL, this is critically low and highly unsafe for any surgical procedure. Above 50 by 10 E9 Lel, this threshold is commonly used as a cutoff for surgical procedures where bleeding risks are manageable, but still a concern, such as in dental extractions or minor surgery. Question 1. Post-transfusion reaction and blood group compatibility. Correct answer, F. All are correct. Explanation. O group blood, known as the universal donor, blood from an O group donor, can typically be transfused to patients with any ABO blood group, A, B, A, B, O, without causing a hemolytic transfusion reaction. This is because O group red blood cells do not carry A or B antigens, reducing the risk of antibody-mediated destruction in the recipient. Recipient groups Group A can safely receive O group blood. Group B can safely receive O group blood. Group AB can safely receive O group blood. AB is the universal recipient type. Group O can only receive O group blood, making it the safest choice for O group recipients. Question 2. Immunosuppressive treatment. Correct answer, C. Aplastic anemia. Aplastic anemia? This is a condition where the bone marrow fails to produce sufficient new cells to replenish blood cells. The treatment often involves immunosuppressive therapy. Anti-lymphocyte globulin and cyclosporin A. These medications are used together to suppress the immune system and prevent it from attacking the bone marrow, thereby allowing the marrow to recover and resume normal blood cell production. Other conditions listed. These other diseases, e.g. lymphoblastic leukemia, immunohemolytic anemia, etc., have different primary treatments focusing on the specific pathophysiology involved. Question 3. Use of irradiated cellular blood products. Correct answer, C. After bone marrow transplantation. Explanation: bone marrow transplantation. Post-transplant, patients have a significantly weakened immune system. Irradiated blood products are used to prevent transfusion-associated graft versus host disease, TAGVHD, a potentially fatal complication. Irradiated blood products. These are treated to deactivate donor T lymphocytes that could cause TAGVHD in immunocompromised recipients. Applicability to other patient groups. While irradiated blood products are sometimes considered for other severely immunocompromised patients, the specific indication after bone marrow transplantation is due to the high risk and severity of potential complications. These are important topics for understanding blood product compatibility and immunosuppressive therapies, both of which are crucial in various medical treatments and scenarios. Question 1. When not to use irradiated cellular blood products. Correct answer, E, with severe immunodeficiency. Explanation. Irradiated cellular blood products, primarily used to prevent transfusion-associated graft versus host disease, TAGVHD. This precaution is vital for recipients who have received bone marrow transplants or are otherwise highly susceptible to this complication due to an exceptionally compromised immune system. Severe immunodeficiency. Contrary to the indication in the test question, patients with severe immunodeficiency are actually among those who may benefit from irradiated blood products because of their reduced immune function, which could be overwhelmed by donor T cells. Therefore, the correct answer, in practice, should suggest that these patients should receive irradiated products, not avoid them. The provided answer choice assumes an incorrect context where it's not suitable for those with severe immunodeficiency. Anemia. Question 1. Characterization of iron deficiency anemia. Correct answer, D. Microcytic hypochromic. Explanation. Iron deficiency anemia, characterized by smaller than normal red blood cells, microcytic, that have decreased hemoglobin content, hypochromic, reflecting a deficiency in iron, which is crucial for hemoglobin production. Question 2. Laboratory findings in iron deficiency. Correct answer, A. Iron deficiency. Explanation. FeTIBC ferritin. These laboratory findings are indicative of iron deficiency anemia. Fe, low serum iron, indicates a shortage of available iron. TIBC, total iron binding capacity, increased as the body attempts to capture more iron. Ferritin reflects depleted iron stores in the body. Question 3. Characteristic abnormality of plasma iron studies in iron deficiency. Correct answer, AFA, TIBC, ferritin. Explanation. This pattern of laboratory results is diagnostic for iron deficiency, emphasizing a lack of iron availability, increased demand or capacity for iron binding due to deficiency, and low storage levels indicated by ferritin. These details about anemia and the use of irradiated blood products are crucial for understanding the management of different patient conditions and are integral to medical education and practice. CHASH Iron Deficiency Anemia in Postmenopausal Women. Question 1. Management of iron deficiency anemia in postmenopausal women. Correct answer. E. Investigation of the cause of possible bleeding, alimentary tract. Explanation. Postmenopausal age. In women of this age group, iron deficiency anemia is often due to blood loss rather than dietary insufficiency. Bleeding from the alimentary tract. Common causes include gastrointestinal conditions such as ulcers, cancers, or polyps. Thus, diagnosing the source of bleeding is critical to effective treatment. Causes of iron deficiency anemia. Question 2. Causes not associated with iron deficiency anemia. Correct answer. B. Colon resection. Explanation. Colon resection generally does not cause iron deficiency anemia directly, since the colon is primarily involved in water and electrolyte absorption, not iron. Iron is absorbed in the duodenum and upper jejunum, making surgeries affecting these areas, like gastric or ileal resection, more likely to cause iron deficiency. Diagnostic features of iron deficiency anemia. Question 3. Laboratory findings suggesting iron deficiency anemia. Correct answer, E. Iron deficiency anemia, explanation, MCV, mean corpuscular volume, MCH, mean corpuscular hemoglobin, MCHC, mean corpuscular hemoglobin concentration, ferritin. These findings are typical of iron deficiency anemia. Low MCV, MCH, and MCHC indicate that the red blood cells are smaller than normal and contain less hemoglobin, while low ferritin reflects depleted iron stores. These insights into the diagnosis and management of iron deficiency anemia are crucial, especially in specific populations such as postmenopausal women, where the identification of the underlying cause can significantly influence treatment and outcomes. Epidemiology of iron deficiency anemia. Correct answer. A. Childbearing aged women have a high incidence of iron deficiency anemia due to loss of iron with pregnancies and menses. Explanation. Childbearing age. Women in this group are particularly susceptible to iron deficiency anemia, primarily due to menstrual blood loss and the increased iron demands of pregnancy. Iron loss, regular menstruation, and pregnancy-related blood volume expansion can significantly deplete iron stores unless adequately supplemented. Analysis of incorrect options. Option B, iron deficiency caused solely by diet is uncommon in populations where meat, a rich source of heme iron, which is readily absorbed, is a significant part of the diet. Option C, in men and postmenopausal women, iron deficiency anemia is uncommon unless there is a source of chronic blood loss, such as gastrointestinal bleeding. D. There is no direct correlation between tobacco use and a higher rate of iron deficiency in older men. Tobacco use might contribute to other health issues, but not directly to iron deficiency. Option E, the statement that approximately 70% of premenopausal women are iron deficient is exaggerated, While the prevalence is high, it is not this high. Oral iron therapy. Question, choose not correct about oral iron therapy. Correct answer, F. All answers are correct. Explanation A. Daily dose of 200 milligrams. This is a typical daily dosage for iron supplementation and treating iron deficiency anemia. B. Taken on empty stomach. Iron supplements are absorbed best on an empty stomach, though they may cause gastrointestinal upset for some individuals. C. Reticulocytes increase after 4 to 7 days. A reticulocyte response indicating new red blood cell production typically begins within a week after starting iron therapy. D. Hemoglobin should increase by 2 grams DL after 1 month of therapy. An effective response to oral iron therapy is typically seen as a rise in hemoglobin levels by about 1 to 2 grams after a month of treatment. E. Continue to treat after 3 to 12 months after obtaining the proper level of hemoglobin. Continuing iron supplementation beyond the normalization of hemoglobin levels is recommended to replenish body iron stores, often for several months. Each point under the oral iron therapy section accurately reflects standard treatment practices for iron deficiency anemia. Hence, none of the statements are incorrect. Question 1. Treatment for anemia of chronic diseases. Correct answer C. Recombinant erythropoietin, darbepoetin alpha. Explanation. Anemia of chronic diseases, often associated with chronic inflammation or chronic disease states, which interfere with iron utilization and erythropoiesis. Recombinant erythropoietin, particularly effective as it stimulates red blood cell production in the bone marrow, which can be suppressed in chronic diseases due to inflammatory cytokines. Role of iron supplementation. While iron supplementation can be part of the management if iron deficiency is also present, it is often not the primary treatment due to the iron sequestration that occurs with chronic diseases. Question 2. Specific symptom of B12 deficiency. Correct answer. E. Neurological changes. Explanation. B12 deficiency. Unlike iron deficiency, vitamin B12 deficiency often leads to neurological changes, including numbness, tingling in the hands and feet, muscle weakness, and changes in mental status due to its role in myelin synthesis and neurological function. Comparison with iron deficiency primarily affects erythropoiesis and does not typically cause neurological symptoms. Question 3. Evaluation of a young woman with symptoms suggestive of anemia. Correct answer E. All answers are correct. Explanation. Symptoms and signs. Fatigue, palpitations, and pallor are classic signs of anemia. The low MCV, mean corpuscular volume, suggests a microcytic anemia, typically indicative of iron deficiency. Relevant questions to ask. Diet. Essential to assess dietary intake for potential iron deficiency causes. Chronic disease. Some chronic diseases can lead to anemia. Trauma. To check for any history of significant blood loss. Previous infections. Some infections can lead to anemia through various mechanisms, including nutritional deficiencies or direct effects on the bone marrow. Collecting comprehensive information through these queries is crucial to pinpoint the underlying cause of her anemia and guide appropriate management strategies.
1. B12 deficiency anemia is correct answer. B. Macrocytic, hyperchromic explanation. Vitamin B12 deficiency leads to macrocytic anemia, where red blood cells are larger than normal, macrocytic, and have a high hemoglobin concentration, hyperchromic. This type of anemia is also often referred to as megaloblastic anemia due to the presence of large, abnormal red blood cells, megaloblasts, in the bone marrow. 2. Vitamin B12 deficiency results in correct answer. B. Macrocytic anemia and neurologic disorders explanation. Vitamin B12 is crucial for DNA synthesis and maintaining healthy nerve cells. A deficiency in vitamin B12 can cause macrocytic anemia and neurological disorders, which might include symptoms such as numbness, tingling, muscle weakness, and problems with balance. 3. The cause of vitamin B12 deficiency is correct answer. Circa gastrectomy explanation. Gastrectomy, or the surgical removal of part or all of the stomach, can lead to vitamin B12 deficiency. The stomach produces intrinsic factor, which is essential for the absorption of vitamin B12 in the small intestine. The absence or reduction of intrinsic factor production due to gastrectomy can impair vitamin B12 absorption, leading to deficiency. (1) The cause of vitamin B12 deficiency is not correct answer. D. GI bleeding explanation. While gastrointestinal GI bleeding can lead to anemia, it does not specifically cause vitamin B12 deficiency. Vitamin B12 deficiency is typically caused by factors that affect the absorption or intake of the vitamin, such as alcoholism, which can damage the stomach lining and the liver, autoimmune conditions like pernicious anemia that result in the destruction of red cell antibodies, or surgical procedures like gastrectomy that remove the part of the stomach responsible for producing intrinsic factor, which is essential for B12 absorption. 2. B12 malabsorption may not be caused by correct answer. A. Colon resection explanation. Vitamin B12 is absorbed in the ileum, not the colon. Therefore, a resection of the colon should not typically impair B12 absorption, unless it somehow affects the ileum or the upstream small intestine. Conditions such as Crohn's disease with ileum involvement, ileum resection, or gastric resection, and certain endocrine conditions such as Addison's disease can impact the ileum or other parts of the digestive system involved in B12 absorption, leading to malabsorption of the vitamin. 3. Treatment of vitamin B12 deficiency anemia. Correct answer. B. 1000 UG per week cobalamin until HB returns to normal. Explanation. Treatment for vitamin B12 deficiency anemia usually involves the administration of cobalamin, vitamin B12. This can be given as intramuscular injections and the frequency can vary depending on the specific needs of the patient. A common regimen might be 1000 micrograms per week until the hemoglobin levels return to normal, followed by monthly injections for life in cases such as pernicious anemia. Folic acid can be used to treat folate deficiency anemia, but it is not a treatment for vitamin B12 deficiency anemia and, if given alone, could potentially mask the anemia caused by vitamin B12 deficiency without addressing the underlying neurologic damage. Therefore, option D, all of the above, is not correct because folic acid is not a treatment for B12 deficiency anemia.
Correct answers and explanations. 1. Correct indicator of response following B12 replenishment. Reticulocytosis in 5 to 7 days. This is a correct indicator of a successful response to vitamin B12 treatment in cases of B12 deficiency anemia. Reticulocytosis reflects an increase in the production of red blood cells as the bone marrow recovers, usually observable within a week after initiation of therapy. 2. Laboratory finding not associated with hemolytic anemia. Elevated haptoglobin. In hemolytic anemia, haptoglobin levels are typically decreased, not elevated. Haptoglobin is a protein that binds free hemoglobin released from erythrocytes. In hemolytic conditions, this binding capacity is exceeded, leading to low levels of haptoglobin. 3. Test not useful in the diagnosis of hemolytic anemia. Creatinine level. Creatinine levels are used to assess kidney function and are not directly relevant to diagnosing hemolytic anemia. The tests relevant for hemolytic anemia primarily involve evaluating red blood cell destruction and include absolute reticulocyte count, serum bilirubin concentration, lactic dehydrogenase, LDH, and complete blood count. These answers clarify the specific indicators and relevant tests for assessing B12 deficiency treatment and diagnosing hemolytic anemia. Here are the correct answers and explanations for each of the questions you provided. 1. Immune hemolysis is diagnosed by correct answer A. Coombs test. Explanation. The Coombs test, also known as the antiglobulin test, is used to detect antibodies that act against the surface of your own red blood cells. This test is essential for diagnosing conditions where immune mechanisms lead to hemolysis, such as autoimmune hemolytic anemia. 2. Which list contains only the tests that are useful for establishing diagnosis in a patient with suspicion of hemolysis? Correct answer: E. Coombs test, complete blood count, serum bilirubin concentration. Explanation. This combination of tests is crucial for diagnosing hemolysis. The Coombs test identifies immune-mediated red cell destruction. A complete blood count, CBC, can show anemia and other cellular changes indicative of hemolysis, and serum bilirubin concentration can be elevated due to the breakdown of red cells. 3. Pancytopenia is characteristic for. Correct answer: C. Aplastic anemia. Explanation. Aplastic anemia is characterized by pancytopenia, which is the reduction or absence of all types of blood cells, red cells, white cells, and platelets, due to failure or suppression of the bone marrow. This condition leads to severe forms of anemia, increased risk of infections, and bleeding complications due to low platelet counts. Here are the correct answers and explanations for the questions you asked. 1. Dry tap is characteristic for. Correct answer: A. Aplastic anemia. Explanation. A dry tap occurs when a bone marrow aspiration yields little or no marrow cells. This is characteristic of aplastic anemia, where the bone marrow fails to produce adequate amounts of blood cells, often resulting in an absence or severe reduction of marrow elements. 2. Reticulocytosis is not present in. Correct answer: B. Aplastic anemia. Explanation. Reticulocytosis, which is an increase in the number of reticulocytes' immature red blood cells, is not present in aplastic anemia. In aplastic anemia, the bone marrow's failure leads to a decrease in all types of blood cells, including reticulocytes. 3. Treatment of choice of aplastic anemia in young patients is. Correct answer: A. Allogeneic bone marrow transplantation. Explanation. For young patients with aplastic anemia, allogeneic bone marrow transplantation is often the treatment of choice if a suitable donor is available. This procedure can potentially cure the disease by replacing the defective bone marrow with healthy marrow from a donor. Here are the correct answers and explanations for the questions you posed. 1. What is the best treatment for a patient with anemia due to chronic renal failure? Correct answer, D. Erythropoietin. Explanation. Erythropoietin is a hormone produced by the kidneys that stimulates red blood cell production. In chronic renal failure, the kidneys often fail to produce enough erythropoietin, leading to anemia. Administering synthetic erythropoietin can effectively treat this type of anemia by stimulating the bone marrow to produce more red blood cells. 2. Which of the following anemias are most likely to respond to the administration of erythropoietin? Correct answer, D. Anemia of renal disease. Explanation. Anemia of renal disease is directly linked to a deficiency in erythropoietin due to kidney dysfunction. Administering erythropoietin is particularly effective for this condition because it addresses the underlying cause of the anemia, insufficient erythropoietin production. 3. Which of the following is a cause of a microcytic anemia? Correct answer, B. Bleeding duodenal ulcer. Explanation. A bleeding duodenal ulcer can cause microcytic anemia due to chronic blood loss, which leads to iron deficiency. Iron is crucial for hemoglobin synthesis, and its deficiency results in smaller red blood cells, microcytosis. Other conditions listed are not typically associated with microcytic anemia. Here are the correct answers and explanations for the leukemia-related questions. 1. Which of the following is the most common leukemia with 25% incidence? C. Acute myeloid leukemia, AML. Explanation. Acute myeloid leukemia, AML, is one of the more common types of leukemia among adults, but it is not necessarily the most common overall. In fact, chronic lymphocytic leukemia, CLL, is often considered the most common type of leukemia in Western countries. However, the incidence can vary by age group and geographic region. The prompt's answer of AML may reflect a specific context or population. Typically, CLL would be considered more common in the general population. 2. Which of the following features is characteristic for acute leukemia? Correct answer, D. Hiatus leukemicus. Explanation. Hiatus leukemicus refers to a gap in the maturation of white blood cells typically seen in acute leukemia. In acute leukemias, there is an abundance of very immature white cells, blasts, with a relative absence of intermediate forms. This is characteristic of the rapid and disordered growth of leukocytes in these diseases. 3. The peripheral blood smear shows blasts 77%, neutrophils 10%, lymphocyte 13%. It is characteristic for correct answer, A. Acute leukemia. Explanation. A peripheral blood smear showing a high percentage, 77% in this case, is characteristic of acute leukemia. This finding indicates a large number of immature white blood cells, which is a hallmark of acute forms of leukemia. This is consistent with the disruption of normal blood cell production, where the bone marrow produces a large number of immature cells that do not function properly. Here are the correct answers and explanations for your questions regarding leukemia. 1. If increase in white blood cell and pancytopenia. Correct answer, A. Acute leukemia. Explanation. In acute leukemia, an increase in white blood cells is typically due to a large number of blasts, which are immature white blood cells. Pancytopenia can also occur despite the high white cell count because the blasts overcrowd the bone marrow, inhibiting the production of normal blood cells, red cells, mature white cells, and platelets. 2. The diagnosis of acute leukemia is based on. Correct answer, D. Presence of at least 20% blast cells in the blood or the bone marrow. Explanation. The diagnosis of acute leukemia is indeed based on the presence of at least 20% blasts in the bone marrow or blood. This criterion helps differentiate acute leukemia from other hematologic disorders where blasts may be present but not as prominently. 3. Choose the best answer about acute leukemia. Correct answer, D. Genetic abnormalities are more important than immunophenotyping for establishing diagnosis. Explanation. While immunophenotyping is crucial for classifying leukemia subtypes, genetic abnormalities often provide essential diagnostic and prognostic information, particularly in acute leukemias. For example, certain genetic changes can define specific subtypes of leukemia, such as acute promyelocytic leukemia, APL, which is characterized by the T517 translocation. These genetic insights can be critical for determining the appropriate treatment strategy and prognosis. Here are the correct answers and explanations for your questions about acute lymphoblastic leukemia, ALL. 1. Acute lymphoblastic leukemia, ALL. Correct answer, E. Majority of ALL can be cured. Explanation. Indeed, the majority of ALL cases can be cured, especially in children, with current treatment protocols that include chemotherapy and, in some cases, stem cell transplantation. The cure rates in children can exceed 80%, making this an accurate statement. 2. Which of the following is not the symptoms of acute lymphocytic leukemia? Correct answer, C. Hypercalcemia. Explanation. Hypercalcemia is not typically associated with acute lymphocytic leukemia, ALL. It is more commonly seen in cancers that affect bone metabolism directly, such as multiple myeloma or certain solid tumors. Symptoms of ALL usually include bleeding gums, shortness of breath, frequent infections, and fever, all related to bone marrow failure or the effects of leukemic cells in various organs. 3. What will you expect in all? More than one answer is correct. Correct answer, D. 25% of TDT polymerase blast cells in M. Explanation. Terminal deoxynucleotidal transferase, TDT, is a DNA polymerase found in the nuclei of pre-lymphocytes, which are abundant in ALL. This is a marker typically used to identify lymphoblasts rather than myeloblasts or other cell types. Incorrect inclusion. E. 20% of myeloperoxidase blast cells in M stats. Correction. Myeloperoxidase is characteristic of myeloid cells, not lymphoid cells. In ALL, the blasts are typically negative for myeloperoxidase, which is used to differentiate from acute myeloid leukemia, AML, where myeloperoxidase positive blasts are common. The provided options and your correct marking emphasize the importance of specific markers in diagnosing and differentiating types of leukemia. Here are the correct answers and explanations for your questions about acute lymphoblastic leukemia, AL. 1. Which sentence best describes the prognosis of acute lymphoblastic leukemia? Correct answer, C. Most of the patients will achieve remission after treatment, but there is a high percentage of relapse. Explanation. This statement accurately reflects the prognosis for many patients with ALL. While a significant number of patients, especially children, achieve remission with initial treatment, there remains a substantial risk of relapse, which is a major concern in the management of ALL. The other options either underestimate the survival rates, especially in children, or provide incorrect generalizations about age-related outcomes. Verb 2. Which of the following is appropriate for the treatment of acute lymphoblastic leukemia? Correct answer, B. Vincristine. Explanation. Vincristine is a key component of chemotherapy regimens used to treat ALL. It is typically used in combination with other drugs to treat this type of leukemia effectively. Rituximab is primarily used in the treatment of some types of non-Hodgkin lymphoma and chronic lymphocytic leukemia, not typically in ALL. Vinblastine, hydroxyurea, and calcium channel blockers are not standard treatments for ALL. 3. A 5-year-old boy presented to the emergency department with high-grade fever and ear pain for the past 5 days. What might be the possible cause? Correct answer, B. Acute lymphoblastic leukemia. Explanation. The symptoms described, high-grade fever, ear pain, enlarged cervical lymph nodes, and splenomegaly, can be associated with acute lymphoblastic leukemia, especially in a child. The presentation could be a manifestation of the general effects of bone marrow failure and infiltration of abnormal lymphocytes, which is typical in ALL. Although Burkitt lymphoma could present similarly, the overall symptoms and age are more suggestive of ALL. Other options like acute myelocytic leukemia, myelodysplastic syndrome, and chronic lymphoblastic leukemia are less likely given the age of the patient and the specific symptoms mentioned. Here are the correct answers and explanations for your questions regarding acute myeloid leukemia, AML. 1. AML, correct answer, D. More common in elderly population, median age 65 to 68. Explanation. Acute myeloid leukemia is indeed more common in the elderly population, with the median age at diagnosis typically between 65 and 68 years. This fact reflects the higher incidence of AML in older adults, highlighting the impact of age on the risk of developing this type of leukemia. 2. Acute myeloid leukemia, AML. Correct answer, C. Translocation 821 is associated with better outcome. Explanation. The translocation T821 in AML is one of the genetic markers associated with a relatively better prognosis compared to other genetic abnormalities in AML. This specific translocation is typically found in a subset of AML patients and is associated with a favorable response to treatment and longer survival times. Other options, such as the role of monoclonal antibodies and trephine biopsy as a necessity for diagnosis, do not universally apply to AML or are incorrect. 3. Acute myeloid leukemia can present with which of the following? Correct answer, E. All answers are correct. Explanation. Acute myeloid leukemia can indeed present with a variety of symptoms, including seizures, which can be caused by central nervous system infiltration or metabolic disturbances, shortness of breath, resulting from anemia or leukostasis, a complication where leukemic cells clog blood vessels, skin nodules, known as leukemia cutis, which indicate infiltration of the skin by leukemic cells, pancytopenia, a common finding due to the suppression of normal bone marrow function by leukemic blasts. These symptoms collectively highlight the diverse and systemic impact of AML on the body.
Your answers to the multiple choice questions are correct, and here's a brief explanation for each. 1. Highest incidence of leukemia in trisomy 21, Down syndrome. Correct answer. D. All. Acute lymphoblastic leukemia. Children with Down syndrome have a significantly increased risk of developing ALL. The incidence of leukemia in Down syndrome is estimated to be around 10 to 20 times higher than in children without Down syndrome. Acute lymphoblastic leukemia is the most common form, particularly prevalent in this demographic. 2. Most common presenting complaint with acute myeloid leukemia, AML. Correct answer. B. Fatigue. Fatigue is the most common presenting symptom in patients with AML due to anemia caused by the replacement of normal bone marrow with leukemic cells. This leads to decreased production of normal blood cells. Other symptoms like fever, abnormal hemostasis, and bone pain can occur, but are not as universally present as fatigue. 3. Not typical for acute promyelocytic leukemia, M3. Correct answer, E. Gingival hyperplasia. Acute promyelocytic leukemia, classified as M3, typically does not include gingival hyperplasia among its manifestations. This type of leukemia is more characteristically associated with DIC-like coagulopathy due to the presence of promyelocytes with procoagulant activities and the T1517 chromosomal translocation leading to the PML-RRA fusion gene crucial for diagnosis. Gingival hyperplasia is more commonly associated with acute myelomonocytic leukemia, M4. These answers are tailored to provide a high-yield review useful for medical students and professionals in understanding the specific characteristics of these diseases as they prepare for exams. Your selections for the multiple choice questions are correct, and here are detailed explanations to deepen your understanding. 1. Chloroma, myeloid sarcoma. Correct answer. A. Variant of acute myeloblastic leukemia. Chloroma, or myeloid sarcoma, is a solid tumor composed of immature myeloid cells. It is often associated with acute myeloid leukemia, AML, but can occur in the absence of overt leukemia. The tumor can present in any part of the body, but is commonly found in the skin, bone, soft tissues, and lymph nodes. 2. Complete remission of acute leukemia. Correct answer, B. Decrease of the number of leukemic cells below the level detected using classic methods, less than 5% blast cells in bone marrow periphery. Complete remission in leukemia implies that there are less than 5% blasts in the bone marrow and no signs of disease are evident with routine diagnostic techniques, and normal hematopoietic function is restored. This state is not equivalent to a cure, but is a critical endpoint in treatment aimed at achieving a cure. 3. Consolidation of remission in treatment phase. Correct answer, C. Acute lymphoblastic leukemia. Consolidation therapy is a phase of treatment in acute lymphoblastic leukemia, ALL, that follows induction therapy. Consolidation aims to eliminate any remaining leukemic cells that are not detectable with standard diagnostic tools, thus reducing the risk of relapse. This phase is crucial for increasing the chances of long-term remission and potentially cure. These detailed explanations are designed to clarify the specific aspects of each condition, enhancing your preparation for medical examinations and clinical practice. Your answers are correctly selected. Here are detailed explanations for each to enhance your understanding, especially for examination preparation and clinical application. 1. Chronic myelocytic leukemia, genetic association. Correct answer, translocation 922, Philadelphia chromosome. Chronic myelogenous leukemia, CML, is primarily associated with the Philadelphia chromosome, which is the result of a translocation between chromosomes 9 and 22, T922. This genetic mutation leads to the formation of the BCR-ABL fusion protein, an abnormal tyrosine kinase that drives the proliferation of leukemic cells. 2. Diagnosis based on clinical and laboratory findings. Correct answer: a chronic myeloid leukemia. The symptoms described, weight loss, fatigue, fever, night sweats, splenomegaly, anemia, and bruising, are classic for chronic myeloid leukemia. The laboratory findings of increased white blood cells, specifically myelocytes, basophils, eosinophils, and neutrophils, alongside a hypercellular bone marrow and the presence of the Philadelphia chromosome, confirm the diagnosis of CML. This comprehensive clinical presentation and diagnostic findings are typical of CML. 3. Characteristics of chronic lymphocytic leukemia, CLL. Correct answer: E. All answers are true. CLL often presents asymptomatically in its initial phases and may be discovered incidentally during routine blood tests. Over time, serious cases can become resistant to treatment, leading to inefficiencies in managing the disease. CLL is associated with autoimmune complications, notably autoimmune hemolytic anemia. Furthermore, CLL cells typically express CD5 and CD23, along with being B lymphocytes, which helps in distinguishing CLL from other forms of leukemia. These explanations provide a robust overview of each disease's characteristics, diagnostic markers, and clinical manifestations, all of which are crucial for medical professionals and students in the field. Your answers are accurate. Here are the detailed explanations for each. 1. Anemia in chronic lymphocytic leukemia may be secondary to accept. Correct answer: C. Hypersplenism. In chronic lymphocytic leukemia, CLL, anemia can develop due to various reasons, such as bone marrow suppression by infiltrating leukemic cells and autoimmune hemolysis. However, hypersplenism, which involves the spleen sequestering and destroying blood cells, is more commonly linked to conditions like myeloproliferative disorders and is not a typical feature of CLL. Therefore, hypersplenism is the exception among the listed options. 2. Indications for splenectomy. Correct answer: C. Chronic leukemia. Splenectomy may be indicated in chronic leukemias primarily when there is massive splenomegaly causing discomfort, hypersplenism, excessive destruction of blood cells by the spleen, or as a palliative measure to improve quality of life. It is less commonly performed in acute leukemias, where treatment focuses on chemotherapy and other systemic therapies. 3. Blood neoplasm that does not require treatment at an early stage. Correct answer: E. Chronic lymphocytic leukemia. Chronic lymphocytic leukemia, CLL, often progresses very slowly, and many patients are asymptomatic at the time of diagnosis. In early-stage CLL, active monitoring, often called watchful waiting, without immediate treatment is a common approach if the patient shows no symptoms or significant blood abnormalities. This strategy helps to avoid the side effects of treatment until it becomes necessary due to disease progression. These explanations provide clarity on the nuances of disease management and diagnostic criteria essential for medical and dental professionals in training and practice. Your selections for the multiple choice questions are correct. Below are detailed explanations to provide further clarity and enhance your understanding. 1. Blood neoplasia, frequently discovered by incidentally performed complete blood count. Correct answer: A. Chronic lymphocytic leukemia, CLL. CLL is often asymptomatic and frequently detected incidentally during routine blood work that shows increased lymphocyte counts. Patients might not present any symptoms initially, making incidental discovery during unrelated medical checks common. 2. distinguishing between leukemoid reaction and chronic myeloid leukemia, CML. Correct answer, D. Presence of metamyelocytes. The presence of metamyelocytes in the peripheral blood is more indicative of CML. A leukemoid reaction, which is a reactive increase in white blood cell count, usually due to infection or stress, typically does not present with the same immature granulocytic cells, such as metamyelocytes, found in CML. Additionally, the Philadelphia chromosome or BCR-ABL1 gene rearrangement would confirm CML, which is absent in leukemoid reactions. 3. Condition associated with leukostatic manifestations, unexplained fever, pruritus, and elevated or normal platelet counts. Correct answer, C. CMLs. These symptoms are typical during the chronic phase of chronic myeloid leukemia, CML. Leukostatic manifestations arise due to very high white blood cell counts, which can clog blood vessels and impair circulation. Unexplained fever and pruritus, itching, can also occur in CML, often related to the body's inflammatory response to excessive leukocyte production. Elevated or normal platelet counts are common in CML, reflecting the disease's myeloproliferative aspect. These explanations highlight critical diagnostic features and common clinical presentations associated with these hematologic conditions, crucial for both examination preparation and effective clinical practice. Your answers are correct and well-informed. Here are detailed explanations for each choice. 1. Laboratory criteria for diagnosis of chronic myeloid leukemia in the accelerated phase. Correct answer, E, C, and D are correct. The accelerated phase of chronic myeloid leukemia, CML, is defined by several criteria, including increased blasts in the blood or bone marrow, 10 to 20% blasts as per WHO criteria, and the presence of 10 to 19% promyelocytes and blasts combined. The option including both C, promyelocytes and blasts in blood or bone marrow co 30%, and D, blood or bone marrow blasts 10 to 20% according to WHO, reflects this intermediate phase before progressing to blast crisis, which is characterized by 20% blasts. 2. Unexpected laboratory finding in a patient with CML. Correct answer, A, elevated leukocyte alkaline phosphatase activity, SRAP. Typically, in patients with CML, the leukocyte alkaline phosphatase, LAP, score is low, contrary to what might be seen in other leukocytic disorders. This low LAP score is due to the proliferation of cells that are derived from the malignant clone, which lack adequate levels of this enzyme. The other options, leukocytosis with leftward shift, eosinophilia, thrombocytosis, and anemia, are common findings in CML and align with the disease's pathophysiology. 3. Likely cause of early satiety, left upper quadrant pain, and Kehr's sign. Correct answer, D, CML. Kehr's sign, which involves referred pain to the left shoulder, is suggestive of splenic irritation or splenic infarction. Given the symptoms of early satiety and left upper quadrant pain, these are typical of splenomegaly, a common finding in CML due to the accumulation of malignant cells in the spleen. The symptomatology and physical findings strongly suggest CML as the most likely diagnosis, consistent with its clinical presentation. These explanations are crafted to provide a comprehensive understanding of the diagnostic criteria and clinical manifestations associated with chronic myeloid leukemia, which is essential for effective diagnosis and management in medical practice. Your answers are accurately selected based on the descriptions and potential symptoms associated with each condition. Here are detailed explanations to expand on your understanding. 1. Likely diagnosis for a 75-year-old patient with the described symptoms. Correct answer, C. Chronic lymphocytic leukemia, CLL. CLL is characterized by the accumulation of functionally incompetent lymphocytes, leading to immune suppression and increased infections. The clinical presentation of fatigue, weight loss, recurrent infections, enlarged lymph nodes, splenomegaly, pallor, and petechiae aligns closely with CLL. These symptoms reflect the typical immunosuppressive and marrow-infiltrative aspects of the disease. 2. Possible symptoms in a 50-year-old male with abnormal CBC results. Except, correct answer, D, weight gain. Given the high white blood cell count predominantly from granulocytes and the presence of symptoms like low-grade fever, night sweats, and potential splenomegaly indicated by early satiety, the findings suggest a myeloproliferative disorder such as chronic myeloid leukemia, CML. Weight gain is not typical for CML or related conditions, where more common symptoms include weight loss due to increased metabolic demand and systemic illness. 3. Curative treatment for chronic myelocytic leukemia. Correct answer, E. Allogeneic bone marrow transplantation. Allogeneic bone marrow transplantation, allo-BMT, is the only curative treatment for CML, particularly effective in the chronic phase before transformation to blast crisis. This treatment replaces the leukemic bone marrow with healthy donor marrow, aiming to restore normal hematopoiesis. While targeted therapies like imatinib and dasatinib are highly effective in managing CML and maintaining remission, they do not cure the disease, but control its progression. These explanations provide a deeper understanding of the diagnostic and therapeutic aspects of these hematologic conditions, crucial for effective clinical practice and examination preparedness in the medical field. Your selections are correct. Here are the details on why these drugs are used in the management of the specified conditions. 1. Chemotherapeutic agent used in therapy of chronic myelogenous leukemia, CML. Correct answer, C. Hydroxyurea. Hydroxyurea is often used in the treatment of CML to reduce the white blood cell count and control symptoms, particularly in situations where tyrosine kinase inhibitors, TKIs, are contraindicated, not tolerated, or as a temporary measure while awaiting more definitive therapy. It acts by inhibiting ribonucleotide reductase, thereby decreasing DNA synthesis. 2. Second line, sometimes first line, treatment in chronic lymphocytic leukemia. Correct answer, B. Fludarabine. Fludarabine is a purine analog that is commonly used in the treatment of CLL, particularly in younger patients or those in need of more aggressive treatment. It is often part of combination regimens that may include other agents such as cyclophosphamide and rituximab, FCR regimen, depending on the patient's fitness and disease characteristics. Fludarabine works by interfering with DNA synthesis and repair, which is particularly effective against lymphocytes. These explanations underscore the targeted use of chemotherapeutic agents based on the specific cellular mechanisms and disease characteristics, highlighting critical aspects of pharmacotherapy in hematologic malignancies. Your answers to the lymphoma-related questions are correct. Below are detailed explanations for each. 1. Ann Arbor classification, no symptoms. Correct answer, A, no symptoms. In the Ann Arbor staging system used for lymphomas, particularly Hodgkin's lymphoma, the designation A indicates the absence of systemic symptoms, such as fever, night sweats, or weight loss. This classification helps in determining the extent and severity of the disease, which is crucial for planning treatment. 2. Designation for absence of systemic symptoms in lymphoma. Correct answer, A. The A classification is used to indicate that the patient does not have systemic symptoms, which are otherwise denoted by B. This distinction is important in assessing the overall prognosis and can influence the approach to treatment, as systemic symptoms typically suggest a more aggressive disease. Number 3, typical clinical presentation of Hodgkin's lymphoma, except correct answer, D, osteolytic lesion. Hodgkin's lymphoma typically presents with symptoms such as B symptoms, fever, night sweats, weight loss, pruritus and cyclical fever, Pell-Epstein fever. However, osteolytic lesions are more characteristic of multiple myeloma or metastatic diseases rather than Hodgkin's lymphoma. Hodgkin's typically involves lymph node enlargement and may involve extranodal sites, but it does not commonly present with osteolytic bone lesions. These explanations should provide a clear understanding of the classifications and typical clinical presentations associated with lymphoma, which are essential for accurate diagnosis and effective management in clinical settings.